hopefully establish PACES exam in Iraq by the end of this year. Today, the initial plan was to discuss Station 5 and ethics, but given the short duration of time we have and the big and how big Station 5 is, I think we will just stick to Station 5 today. And we already have a dedicated session for ethics on the 9th of March, and hopefully Dr. Mudassar will cover the ethical scenarios for you. I will give you a brief introduction for approximately 5 minutes about Station 5 before we start having our mock scenarios. Okay, let me just share my screen before we start. Can you see my screen?
Yes.
That's excellent. Okay, and just sorry. Just need to do this. Fine, excellent, good. So Station 5 is highly marked in PACES exam, is one of the most important station in this exam. And if you want to guarantee passing this exam, you need to master Station 5. If you look at the grading of the exam, there are different domains or different skills they assess, and some stations have certain domains which are not present in the other station. But the main focus in the exam in general is patient welfare, addressing patient concerns, and how you communicate and how you interact with the patient. This is heavily marked, and if you don't do well in this, unlikely you will do the exam, you will pass the exam. So the main focus when you practice, try to master skill F and G. And if you look at Station 5, you will see that Station 5 covers all 7 domains. So that reflects how important this station is. So addressing concerns in Station 2 and 4 is not enough to pass the exam if you haven't approached the concerns in Station 5. I've come across this a candidate who scored approximately 160 out of 172, which is the final mark in PACES exam. But unfortunately, she failed because she didn't address concerns in Station 5. That's how important it is. So poor performance, unfortunately, most candidates, they show very good clinical knowledge and the skills when it comes to taking history and examining patients in Station 5, but unfortunately, they show poor performance in areas of empathy, concerns management. Because you need to know that the general medical practice in the West and the focus of their exams, whether in medical school exams or PACES exams, is addressing patient concern, which is as the patient is the center of everything. They want you to be a safe, caring, empathetic doctor. Please keep this in mind every time you deal with anything related to PACES or MRCP, or even in your daily practice. Good. This is the most of you have seen this when you're preparing. So this is the PACES exam, how it runs. The timing for each station, as you can see here. If you look at Station 2 and 4, at the moment, the current format, they have the longest the duration or the longest time compared to Station 5, which is collectively is for 20 minutes, but each case will be approximately only for 10 minutes. Because this station, as we said, covers all domains, and it's very important, and it's the heavily marked, and I think it's the highest mark in the exam as a whole. They, in the new exam format, which will I think be established by the end of this year, you will notice that they have removed the history station, and they have reduced their communication station here. And converted them into a quick 10 minutes session that you don't really need to interact with the examiner in them. It's going to be observed communication. So you will interact with the examiner only, and the examiner will assess your, you will interact with the patient only, and the examiner will assess your interaction with the patient. There will be no questions in this. But the 10 minutes which were taken from each station will be added to station 5, and each one will be for 20 minutes to mimic real life situation. And that's to reflect the high grading they put on this station. At the moment, we are sticking to the old format, and I'm not sure what will the mock exam be in Iraq, but sometimes in certain centers there is a rest station. So instead of having 5 stations, you will have an additional rest station. It's important, if you see here, station 5 is the last station here. So if one of the candidates start at station 1, station 5 will be the last for him or her. The reason why I mentioned this is what Dr. Wathak mentioned on Sunday. You need to practice, you need to be fit, because I mean, with example, he mentioned that if you are asked to run a 10-kilometer race and you can only run 2 kilometers, you will not be able to finish the race. The same here. If you have started in station 1, by the end of the 2 hours, which is station 5, you will barely be able to focus and concentrate in order to deal with the highly marked station. So in order to be able to do that, practice is your solution. So practice to maintain fitness, and you need to, if for any reason you did unwell in station 1 or 2, and the next, please try to disconnect from the past, disconnect from that station, because it will affect your next station performance. Just focus on your next step, because you own the future, you own your current moment. Just forget about what happened in the previous stations. This is an important tip I followed in my exam. When I didn't do well in the previous station, I just forgot about it and focused on the next one. And alhamdulillah, I passed. You need to, what else here I wanted to say? So the tips that I need you to keep in mind when you do station 5, please listen and focus to everything the patients say, because it's a very short station. You only have 6 minutes to take history. So everything said is relevant. This is number 1. Number 2, when you ask questions, be very clear, very specific with your wording, direct and simple. Because if your question is not clear, or if you use complicated word, the patient will ask you, what do you mean by this? And this is wasting your own time. Be succinct with your questions. And as Dr. Wathak said on Sunday, on the session on Sunday, don't try to abbreviate your question. Don't use the word do you have, because this will consume your own time. Try to use your body language, your intonation, and just say, any headache, loss of consciousness, dizziness, weakness, just like quick. Use the words quick with your body language. This would help in asking as many as possible questions in this limited time. The other thing, please examine what's relevant only. No one is expecting you to perform a full examination in station 5, because we know we have only 10 minutes to do everything. Take history, examine, address patient concern, and then 2 minutes for discussion. So if you are able to take proper history, you will be able to perform a targeted examination. This is the most important bit. This is, as we say, the elephant in the room. Address patient's concern. If you haven't done so during your history, and the examiner gives you the 6 minutes warning, please stop whatever you're doing and ask the patient, what are your concerns? If you don't do that, you will lose a huge amount of, like a huge bulk of mark, which could easily fail you in the whole exam. Okay, keep to the point. Don't distract yourself with irrelevant things which are not relevant to your present complaint. And or not relevant to the examiner question. So always answer the examiner's question. Don't waffle on about the history they heard you taking. If they ask you, tell me, what did you find in your exam, not the history. Don't say, I examined those, you're wasting your own time. Try to directly, just don't go back and forth around your history. Because you've got only 2 minutes, so use the 2 minutes to talk about science, differential diagnosis, investigations, and management, and if there's any safety netting that needs to be done, any patient education that is important and relevant that you need to mention in, because this is a patient safety thing, like home education at home, that things they need to do in case they become unwell. This is very important. And please don't waste, these are simple things, so don't waste them. It's difficult to grasp everything in one go, so you will master this by practice. Practicing and practicing will help you manage your own time, be fit in a 2 hours exam that requires 100% concentration from you. Only summarize your history if they ask you to summarize. And when you summarize, just mention the pertinent positive, pertinent negative, and relevant drug and past medical history. Don't say everything. You need to practice summarizing your history in 45 to 60 seconds and mention the most important differential diagnosis in 10 to 15 seconds. You can do that if you practice. It's not something impossible. But usually history summary is more relevant to station 2 rather than in station 5. And of course, be flexible. Just focus to the examiners, the way they direct you, and try to be flexible and move towards their direction rather than on your own, following your own agenda. These are my tips for station 5, summary of my own practice, my colleagues' practice, and what I see around. This is my own recommendation, how you divide your time. The way we do it, 3 to 4 minutes. Sometimes you need 4 minutes if the case is a little bit complicated. For history, 2 to 3 minutes for examination, and stop at 6 minutes to address eyes and explain. You have to do that. This is the most important bit here, because you need at least 2 minutes to explain what's going on to the patient, address their concern, and give them a brief a plan of what you're going to do. Okay, any question so far? Because I finished my introduction, we're going next to the clinical scenario. So if you have any question before we go, please go ahead. Yes, Dr. Al-Wata.
Assalamu alaikum, everyone. Thank you, Zainab. It's lovely introduction. I am very happy to see you presenting this very difficult, and I am sure you are making it easy to follow. You have made excellent start. As you mentioned, I'm very pleased that you visited that soon. All these carousels are going to change. So hopefully in the beginning of 2024, this exam will be changed. And this is station 5, which is very stressful and very demanding station, is going to change completely, as you mentioned. So that's very good. For the time being, and I think the mock exam in March, inshallah, will follow this way. It is an introduction to what we have been doing and what is, why did we change it for the best of interest to the candidates and to the patients, and also to fit the 21st century changes in the curriculum of the internal medical training. So something to add on this and at this occasion, with the station 5, as you mentioned, we have only 8 minutes in total, and then the patient and the candidate will have the discussion with the examiners. So what you have recommended, nice division, so the candidates has to start examining the patients while talking to them, rather than take the history for 3 to 5 minutes and then start examining, and then they will find themselves with no time to answer their questions. So this is the only station. It is meant to be like what we do in the post-take word round. We start to introduce ourselves, and for 1 minute, maybe we take the history, and then for the following 2-3 minutes, we can ask the patient permission to start examining them while we talk to them. So this is very important, not to waste time in this station and to start the examination as soon as possible. And as you mentioned, the skills of F and G in this station is very important. It makes a lot of changes to the outcome of the station 5 scoring, which carry out of the 172 mark, it carry up 56 marks in total. So one has to be very careful to divide the time appropriately and assess all the skills in a very in order. So I'm going to stop here, and I am sure that will probably be more clear when you present your cases. And thank you again for your lovely presentation. Really enjoyed it. Well done.
Thank you so much. Thank you. Thank you for your comments. Really appreciate it. We have, let me just go to the, good, okay. So we will have, because I have decided not to do ethics today, so we will have 3 rounds of station 5. Of course, each station 5, they have 2 scenarios in each, so we will be discussing 6 scenarios today. Most of them are real life scenarios, and that's what happens in PACES exam. They bring real life scenarios. And one or two of them were my station 5 cases. So very kindly, Omnia and Ibrahim have volunteered to be our simulated patients. So I'm not sure who is going to be our candidate for the first round, because we'll need 3 candidates tonight. Who is going to be our first volunteer?
So we have Dr. Mahmoud Al-Timimi and Dr. Gaylan with us. If
So
any
shall
of
we
you
start
want...
with Mahmoud or Gaylan, whoever likes to start?
Okay, Dr. Mahmoud. Yes, Dr. Mahmoud, please go ahead.
Excellent. Okay. So Mahmoud. Because I need to start the timer once you are ready. And I'll show you the cases, just like real exam.
Dr. Mahmoud, you need to unmute yourself.
Hello, how are you?
Hi, Dr. Mahmoud. Thank you for volunteering to be our first candidate. Good. So I'll give you 2 scenarios now with exact similar instructions underneath each scenario, which you'll find sorry, in station 5. You have 5 minutes to go through both scenarios, and when the 5 minutes finish, we will start our 10 minutes station 5 for 10 minutes with each scenario. Is that all right? Are you ready?
Yes.
Yeah, go ahead. this is for all of our SMDs. So that's what Dr. Vikram mentioned earlier. One of the instructions you find in station 5, you go to the second point, you do not need to complete the history before carrying out the appropriate examination. And that's what Dr. Vikram was mentioned. So it's fairly acceptable to examine when you ask, or stop history and examine and then go back to history. You do it your own way. Okay, I'll stop sharing and now we can start our simulation. Okay.
Okay.
Go ahead, Dr. Mahmoud.
Okay.
So Ibrahim is your first patient. I think Ibrahim will be simulating. Okay. Yeah. Yeah.
Hello, good evening.
Evening, doctor.
Hello, Mr. Adnan Amir. I am Dr. Mahmoud. I am one of the team in the emergency medicine. I try to solve your medical consultation. Do you accept my attendance?
Hello, doctor. Yeah, thank you so much for your help.
Okay, you are Adnan Amir, 21-year-old male.
Yes, exactly.
Yes, as I know, you are complaining from vomiting with mild confusion and lethargy.
Exactly, yeah.
Yes. Can you tell more about your problem?
Well, doctor, to be honest, I don't know, it was like a week ago, started having like this nausea and vomiting, and I just like feeling tired all the time. So yeah,
Okay, for how long it started your problem?
a week ago, 1 week ago.
1 week?
Yes.
Yes. Later on, how can progress your condition?
I'm sorry.
How can progress start a sudden onset, or is it a gradual?
No, it was like gradually, like it was starting like with just nausea and then like progressed to vomiting, like yeah, day by day.
Okay. Do you have before that time, before 1 week, are you was completely normal without any complaint?
Oh, well, before that, like, I had like diarrhea for a couple weeks, and I went to the hospital for that, but I thought it went like I thought it was resolved. Yeah.
Yes. Before of weeks, you have. I don't hear you clearly.
Yeah, like it was 2 weeks ago. I had like a diarrhea, and then I went to the hospital for it, and they said like it could be like a stomach bug, so it should be resolved on its own. And yeah, just happened that happened.
Okay. After you are taking from a restaurant, do you have any nausea, vomiting at that time?
No,
Yes. Is there is any fever?
no,
Yes. Any abdominal pain?
not really. No.
Yes. Do you have any excess or frequent bowel motion?
Not at the moment. Like that was 2 weeks ago, but now, no, not that.
Yes. Do you have any skin rash developed on your body?
No,
Yes. I asking regarding if there is any fever, no developed fever.
no fever. No.
No fever. Okay. What's about your urination? How can you doing bath in the last weeks?
Um, could you? I guess it's normal. There's nothing wrong. Like yeah, with my urination.
Yeah, okay. And at night, how do you get for your bath?
Could you explain that? What do you mean?
Sorry?
What do you mean by that? Like at night? What do you mean?
Yes, I asking sometimes do you have an excessive urination at night that awake
Oh,
you from sleep?
no, no,
2 minutes left.
Okay. Do you have previously using any medication?
no,
Okay. Do you have any past medical history regarding diabetes mellitus, hypertension?
no.
Okay. Any condition regarding using of family history of any renal problem?
No, but my mom had like an underactive thyroid, and I guess my sister had a gluten sensitivity and also an underthyroid disease.
Oh, sorry, I don't hear you clear.
Oh, my mom had an underthyroid disease as well as my sister, and my sister had like a gluten sensitivity.
Okay. What regarding any history of sorry. Um, yeah, what's your main concern, Mr. Adnan?
Well, to be honest, is like what was concerning me is that I have no idea what's wrong with me. Like I said, I went to the doctor and they said like my illness should resolve in like 2 to 3 days, but so far I haven't seemed to recover and I'm still like ill. So I'm not sure. Like, yeah, that's why I came here. I was hoping like you could help me.
Yes. Sorry for telling you that you have a raise in your or raise in the parameter of your kidney function. We are requiring to do a further analysis for you as related to your history of this raise in the renal parameters, as well as due to you have a family history of your mother and your sister for the kidney problem, required to adjust your condition and give for you some medication, as well as it require you require to admit your for the word for replace you have some deficient in your salt in the blood that require to be replaced carefully and do for your further analysis to settle your condition. Do you have
Yeah.
any concern, Mr. Adnan?
Thank you, doctor. That's a lot to absorb. So, is there something that I need to worry about? Like, is my illness like, so is it gonna resolve, or do I need to worry?
We are requiring further analysis to adjust your condition due to because of the baseline of your family history of the kidney problem. You are later on required to adjust your condition and consult with the a specialty, a team specialty in the kidney disease to adjust your condition. Mostly this is an inherited disease related to a polycystic kidney.
Sorry, can I stop you here, Dr. Mahmoud?
Yes.
So what is your working diagnosis?
Okay, at first, I think the patient has a condition of adult polycystic kidney disease that develop an acute kidney injury at first.
What's your differential diagnosis?
The second, electrolyte loss due to an acute post-infection acute kidney injury.
Okay, and how would you investigate this patient?
I'd require first for doing for him after doing renal indices regarding the blood urea and serum creatinine, serum electrolyte. I require to do for him an arterial blood gas analysis. I require to do for him an abdominal ultrasound, the kidney size and the corticomedullary differentiation, and if exclude others. Also, I require to do for him at this point
what was abnormal in
sorry.
this patient's blood? What was the main thing that was
Most
quite
problem is
abnormal?
the hyponatremia, serum electrolyte, the hyponatremia and hypokalemia at that time.
Okay, and if this patient developed seizure, how would you manage him?
This is considered a severe form of hyponatremia that require to correct him carefully. I require to replace him with the half saline infusion with the monitoring of his serum sodium level, that not more increment in his serum sodium more than in around 5 to 5 milliequivalent per day to avoid the osmotic demyelination syndrome.
Yeah, time finished. Shall we go to the next case, please?
Okay.
Omnia?
Yes.
Hello, I am Dr. Mahmoud. I am one of the team in the emergency medicine. I am dealing with Miss Samira Hazim, 26-year-old.
Yes, that's me.
Okay. As I know from your history, you are feeling not well and with weight loss in the last few weeks. Can you tell more about your condition?
Yes, doctor. It's like in the past 1 month, I'm feeling super tired. I'm like getting worse, always tired and feeling sick. So I don't know what is happening with me.
Yes, this is starting in the last 1 month.
Yes.
Yes, before 1 month you are was without any problem.
Yeah, completely normal.
Okay, completely normal. Do you have, as I know, do you have any nausea or vomiting in this
Oh,
condition?
yes. Yes, I vomited several times. I'm feeling sick all the time.
Okay, do you for how times you are vomiting per day?
Oh, no, it's just like no particular timing. It just happens.
Okay, about the vomiting, is it, can you judge, is the amount, is it cup or more?
I don't know. It's like I'm tired and I'm vomiting a lot, so I don't look at my vomit.
Okay, do you remember the color of the vomiting?
It's like normal, the food I eat.
Okay, is it containing any blood
Oh, no,
content?
no.
No. Is it contain sometimes as a coffee ground colors?
No, as I said, it's just the food I eat.
Okay. Do you have any dysphagia?
What is that?
Sorry, do you have any difficulty in swallowing?
Oh, no, normal.
No. Do you have any abdominal pain?
Yes, like my tummy aches. Yeah.
Yes, especially at which region? Is it at the upper abdomen, one side of the
No, it's just
abdomen?
the center of my tummy.
Okay, can you tell me about this abdominal pain? Is it the character of the pain? Is it this pain looking as colic, heavy in character, or what do you feel it?
I don't know. It's just like constant pain, kind of.
Yes. Yeah, is it start suddenly or gradually?
I haven't noticed, but like when I vomit and so feel the pain.
Sorry, I hearing from this. Do this abdominal pain increase after vomiting or increase with hunger?
Oh, I don't know.
Don't know. Is it there is change in your bowel motion?
No,
Okay. Do you have any skin rash?
no,
Okay. Do you have what's about fever in the last 1 month?
no,
Okay. Do you have, sorry for this question, there is any blood occurring with your bowel motion?
no,
Okay. Do you have any past medical history?
no,
Okay, not doing surgery previously.
no.
Okay. Do you have any family history of same condition?
No.
Okay. What's regarding your urination? How many doing that?
Oh, I noticed that I've been going to the bathroom a lot these days and passing a lot of urine. I'm not like
Okay.
that.
Okay. What regarding bath thing at night?
I told you it's like I'm going like all the time. I'm not like this, so it's happening a
Okay.
lot.
Okay. Do you have what's regarding the volume of the urine? Is it large in amounts or?
Oh yeah, huge.
What's regarding your drinking of water?
I'm drinking water like a lot because I feel I'm thirsty all the time.
Okay, sorry for hearing this. What's your concern, Miss Samira?
Well, what about this pain? It's like 1 month ago and it's keeping getting worse. What is this? So
Okay. Do you have any complaint? Other complaint?
I just need the pain to get off. That's my main concern.
Okay. According from your, after completing your examination, I require to do for you, I require to admit you to medical ward and do for you some blood test to analysis your condition. Regarding the doing for you a blood sugar test to adjust
2
your
minutes left.
condition.
2
Okay.
minutes left.
Yes. Also, I require to analyze your carefully to give you your hint regarding this your condition and to be settled careful.
So I
Do
am
you
to
have
be
any other
admitted.
questions?
I am to be admitted to the hospital.
Yes, you are required to be admitted to the hospital to do for you a blood test and to analyze your condition carefully to judge your condition in a basement manner.
But I have work, so why? Is this serious?
Because you have by examination you have an increase in your heart rate as well as an increase in your respiratory motion. You are requiring to do for you some analysis to judge your condition because we could suspect you have a diabetes mellitus, which is a raise in the blood sugar, and require to judge this and replace you with an IV fluid and to be careful with you.
So this pain because of my sugar?
One of we suspected because of do you have a weight loss, you have an excessive urination, you have an excessive drinking of water, as well as an increase in your respiratory motion. This is give us a feature to replace your with an IV fluid, replace your electrolyte, as well as to control your blood sugar.
But doctor, I've heard that if you have a pain in your tummy and you're losing weight, it might be cancer. Is that what I'm having?
Yeah, at this point, because of you are a young age female as well
Sorry,
as
I
no
have
other
to stop it now.
feature,
Okay.
I think it
Uh,
is less likely to be you have a tumor.
Dr. Mahmoud, so what's your most likely diagnosis?
Yes, this is a case of new onset diabetes mellitus with the features of ketosis.
Okay. And what's your differential diagnosis?
Could be the patient due to weight loss, due to the abdominal pain, tachycardia, and tachypnea. I should exclude also hyperthyroidism and thyrotoxicosis.
What, in your opinion, has it triggered the DKA?
Yeah, because of she has a tachycardia, tachypnea, as well as abdominal pain with vomiting. This is mainly can give a clue regarding a DKA.
How would you investigate this patient?
I doing for her a blood sugar as well as doing for her hemoglobin A1C. I read to want to do for her a kidney function test as well as required to do for her a liver function test. Also, I require to do for her a serum electrolyte. It is very important, and send her for general urine analysis to exclude for any ketonuria.
How would
Also,
you
I
manage this
require to
patient?
do for
How
abdominal
would you manage
ultrasound,
her?
sorry.
How would you manage
Yeah,
this
I
patient?
start with her an admission to medical ward, as well as keep her on an IV fluid, replace her, as well as correction her electrolytes, and for according to the start insulin therapy for hyperglycemia, and according to the potassium level, I should arrange her for potassium replacement.
Okay, I will stop here. Thank you so much.
Yeah.
So tell me, what do you think about the two cases? Were they,
For me,
yes, were they straightforward, or were there any missing information that weren't very clear to help you take history, particularly for the first one?
really, I want to have from you your feedback regarding me, because due to the time, due to the concentration for this short period, I surely I am missing something, but I try to do my best to manage the patient welfare, to manage the patient condition in a straight and successful way.
But is
I
there-
really, I am waiting your feedback for my
Yes,
performance
no
in these two cases.
So this is station 5. We're meant to take history and perform examination. Is there any reason why you didn't perform examination or ask to perform examination
For whom?
for the patient? You could just ask, I would like to perform examination, and we can direct you towards this. Is there any reason why you didn't ask for examination? Or
Yes, I think in the examination, it could be because of the time I require to do examination. Yes.
yes. So our first case was a 21-year-old gentleman who presented to you with vomiting, fluctuated or mild confusion, and hyponatremia. Let me just share the cases again so everyone can see what we're talking about again. So when you see this scenario, and like a young patient with hyponatremia, severe hyponatremia, and the patient is complaining of mild confusion. First of all, this is a severe symptomatic hyponatremia, so you need to keep it in mind. Then your history should focus on why is this patient having hyponatremia when you take history. And for this to happen, you need to have a list of your differential diagnosis in advance before you go into the room, because you're given 5 minutes in advance to prepare the cases. Just write down causes of hyponatremia that I need to exclude in this patient. I wasn't sure what was in the history that directed you towards adult polycystic kidney disease, because this patient's diagnosis is hyponatremia, and if you ask further questions, the patient will mention that they have dizziness, and if you asked for any like postural hypertension, some weight loss, and if you ask further for further information, we could have given you the blood pressure, which was low, and the patient was tachycardic, and this was a typical presentation of adrenal crisis and hyponatremia secondary to number one, adrenal Addisonian crisis, and number two, the gastroenteritis, the nausea, vomiting, and diarrhea he's been having for a week or so. So unfortunately, the diagnosis for this case wasn't correct. The other thing that was in the history, I appreciate that Station 5 requires a lot of practice. So you did introduce yourself, you did address patient concern, but you haven't performed the other skills or domains required for Station 5. So for this case, unfortunately, you wouldn't pass, I'm afraid. As for the second one, which is our lady with a 26-year-old lady with some weight loss and vomiting and abdominal discomfort. You're correct. This is a presentation of DKA, but we need to ask further questions to know why this DKA happened. So you need to exclude infection, you need to exclude stress, you need to exclude pregnancy. So pregnancy is very important. She's a young lady who you didn't ask anything about relevant to help you guide you towards pregnancy. And if you ask for any investigations or management, we have given, I could have given you findings, urine dip findings, and a pregnancy test finding. So this was a case of a pregnant lady who has a first presentation of DKA triggered by her pregnancy. So the diagnosis was partially correct, but again, you didn't perform an examination, and the history was quite long and slow. So with the practice, you need to practice asking questions quickly, and you need to make sure that you address the important relevant concerns covering the differential diagnosis you keep in mind before you go into the room. So you have the 5 minutes, the 5 minutes before going into station 5, you need to use the 5 minutes to list differential diagnosis in your mind that this young male or this young female with this and that, very likely they have these kind of differential diagnosis. I need to exclude in my history. I need to ask about these observations. I need to ask about blood pressure. I need to ask about urine dip. I need to ask about their blood, etc. Whatever is relevant to your case, so that you could efficiently use your 6 minutes during history. So the 5 minutes outside is for you to think what I need to ask, how you stratify your questions, and you need to dedicate time for your targeted physical examination. So unfortunately for this one, you would, I'll leave Dr. Vikra to decide whether to pass for the second case, but you did address concern, which is the highest, highly marked here, but the rest of the domains weren't. I think I would give you borderline for the second one. But I'll see what Dr. Vikra thinks.
Dr. Ibrahim, well, you are مثل ما يقولون يعني the first one to face these two very difficult scenarios. And one thing, you don't have the patients with you, so you can examine them. So I really appreciate that you are in a difficult situation. From what I heard you talking about these two cases, I am very sorry to say, of course, practice will make perfect, and this is the first time. You need to practice a lot. Your way of taking history and the C skill, which is the communication, you interact with the patient, is not very fluent. So I may say you are a bit hesitant. I may say you are a bit unpracticed. I may say you are omitting important information in the history. So this station cover all the 7 skills, and each one of them is very important to take the most important of the information to reach a diagnosis. In the first case, you will fail very clearly, and you will get, in my opinion, unsatisfactory in most of the skills. As I said, the history and the communication was not very clear. I found you unpracticed and unsystematic, and you omitted some information. In making the diagnosis of polycystic kidney disease, correct me if I am wrong, did you say polycystic kidney disease? I don't know on what base you said so. There is hardly anything in the story or in the information to suggest so. So you may say this is hyponatremia, and I want to investigate that. It could be he is a young man. He may be psychologically compulsive water drinker, because even his potassium is low. Although his urea is a bit high, I cannot even make him a Addisonian crisis. So this gentleman, if anything, I will even, sorry to say, I will fail you in skill G, because you have jeopardized the patient safety. This gentleman, he is a young man, he may go home or fitting, and he may have needed to be admitted to the hospital and treated in the acute care unit with emergency and maybe even high dependency unit, because this level of sodium of 109 is critically unwell, and it needs a close close observation. So I'm sorry about this case. The second case, yes, again, I can say you need to practice. You got the diagnosis right, which is fine. But as Dr. Zainab said, in this age group, it's very important to make sure she is not pregnant. Yes, she may be diabetic, not even diabetic ketoacidosis, she could be, but there are different types of diabetes and it needs to be taken like this. And she may even have thyrotoxicosis, as you mentioned, but I felt even in this case, you did, if anything, borderline, but sorry to say also, failed to cover everything in this scenario. So unfortunately, station 5, on this occasion, you failed on the two cases. So I am sorry to disappoint you, but I think we need to learn from our mistakes so we can avoid it in the real exam.
Yes, I apologize as well, but we're here to learn and to improve. We're not here to criticize anyone. Regarding the first case, so the patient is having hypokalemia because there's a 2 weeks history of gastroenteritis and diarrhea and vomiting. So that's why the potassium is low, which is not typical in patients with adrenal insufficiency. But because of the history of diarrhea, that's why hypokalemia is there. And this is a real case. And that patient, I've seen him during my own call, and this patient developed hyponatremic tonic-clonic seizures. So it's very important that we have a very low threshold in diagnosing and managing those patients, trying to have very low threshold to know why he's having a young patient who's fit and well having hyponatremia. Okay. Shall we go for the next one?
Sorry, Dr. Zainab.
Yes.
There are a couple of questions in the chat box regarding this case. So Dr. Rand is asking, can you discuss the examinations of these patients?
Yes. So for the first one, both of them, to be honest, not the first one. When you see such patient, of course, in a simulated scenario online, it's difficult to examine, but I would like to examine, you would say, I would like to perform a general examination for both of them. And then when you perform a general examination, you could ask, it should be enough for those patients, but you could ask to perform abdominal examination because they have presented with vomiting and some abdominal discomfort. For adrenal insufficiency or a dysonium crisis, general examination is enough to pick the signs you need. There's no specific organ in such a case. The second one, of course, it's a GKA. It's a pregnant lady, so general examination as well is enough to appreciate that she's quite tachypneic. Maybe she's cachectic or having low weight. I don't know. Depends on what you depends on real life situation. And the most important bits in both. For the first one, ask for observations. Ask for their blood pressure and heart rate and the vital signs. I didn't put it here because I was waiting for you to ask for it. The second one, I did put the observations, but I didn't put the blood sugars because I was waiting for you to tell me I need to have the blood sugars, I need to have ketones, I need to have their blood gas. And if there's any pregnancy test was performed for this lady, I'd like to have a look at it. So it's okay to ask the examiner, I need this and that to help me manage this patient and aid me through the diagnosis. I intentionally asked Umni and Ibrahim not to disclose any information, so they only answer the questions you ask for. And any additional information required to help you through history, you need to ask for it. Any additional information you require to help you with the diagnosis, you need to ask for it. That's what happens in real exam. Patients are advised not to disclose any information unless you ask for it. Okay. Any other questions, Omnia?
Okay, so thank you so much. There are a couple of questions in the chat box, but for the effect of time, can we just go through the second round and then in the meantime, discuss the questions later?
So we have 5 minutes for the candidate to go through the scenarios and we can answer the question during the 5 minutes. Okay. Yes. Who is our next? Is it Gaylan? Or...
Yes, good night to all of you. I
Hi,
will be
hi,
the
good
second.
evening, Ilan.
Good evening to
So
all
again,
of
you have 5 minutes to go through both scenarios, and we just get the timers ready. And in the meantime, just ignore us because we're going to answer the questions. Okay. Okay, go ahead. Time is on.
Can you just please?
Yes, Onya, if you just let me know about the questions because I can't see them.
Oh, sorry. So someone is asking, can you put hemolytic uremic syndrome in the differential for case 1?
Not really. Nothing. There is no hemolysis. Nothing mentioned. Possibly, but not like it's like a very, very far at the end of the bottom of all of your lists. I would put it there.
Okay, and another
This is a
person.
very, very clear, straightforward hyponatremia in a young patient with abdominal pain and vomiting. First thing you need to keep in mind, and he has a history of gastroenteritis. So it could be gastroenteritis induced like hypovolemic hyponatremia because of 2 weeks history of nausea and vomiting. Gastroenteritis is an acceptable diagnosis, but any patient with hyponatremia, the first thing you need to exclude is adrenal insufficiency, which is a very common and life-threatening thing as well.
Okay, another question is Addisonian crisis causing vomiting and hypokalemia, masking the classic combination of hyponatremia and hyperkalemia in this case. So what is the clue to Addisonians?
The clue is the low sodium and the history. So your history is your clue. You need to ask about postural hypertension, weight loss, change in skin color. You need to take a proper history to get the diagnosis.
And they're asking.
The usernames are not enough in this case.
Mhm. And they're asking about why there is hypo instead of hyperkalemia if it was Addisonian.
Because he's having gastroenteritis for 2 weeks. He's losing his potassium with the diarrhea.
And final question is, would you include anorexia nervosa for the lady in case 2 among the differential?
I mean, you need to exclude it by asking, do you have any depression or any mood changes or any anxiety problems? If they say no, that is unlikely, but nothing, anorexia patient will be cachectic, they will have psychological problems. And it's unlikely in our case who has a very short history of nausea and vomiting. It's not like a prolonged duration, so it's not likely.
Okay, thank you so much. So that's it for the questions in the chat.
What just like a tip. What's common is common. What's common in real life is common in real exams. Sorry. Pregnancy is common, DKA is common, adrenal is common. Hemolytic uremic syndrome is not common, and anorexia nervosa is not common in our community of Iraq, as far as I know. So keep in mind the common things, the life-threatening things, the medical emergencies. These are the common things that you will see. Rare scenario, rare, no one will penalize you if you didn't know a rare diagnosis, but you will definitely be penalized if you didn't know simple, common, life-threatening scenario diagnosis. Sorry. 30 seconds to go. Okay, shall we start? Yeah, go ahead, Gaylan. Ibrahim, if you start
Yep.
with, yeah.
Ready.
Gaylan. Hello, Gaylan, are you with us?
Oh, sorry. Now
Yes.
you can hear me? Okay.
Yes, we
So,
can hear you. Start
good evening.
your district, yeah.
Okay. Good evening. I'm Dr. Gaylan Shazad. I'm one of the junior doctors in the medical department. Are you Mr. Murad Maher?
Yes, that's me.
Okay, and you are 50 years old.
Yes, exactly.
Okay, Mr. Murad, I am here to have a few chats for your current medical state. Then we will proceed to maybe examine your belly and generally. Is that okay with you?
Yeah, sounds good.
Okay, so from the paper that I have, it says that you are complaining of some vomiting and weakness. Can you elaborate more, please?
Well, doctor, I don't know, like, to be honest, for the past 3 days, I've been feeling like tired. Like you mentioned, I've been having like vomiting and nausea. My head hurts sometimes. So yeah,
You have headaches. Okay. So
Yeah.
you said you have headache. Okay. So anything else such as any dizziness, any problem with the hearing,
No.
with disturbance of the consciousness, any
No.
weakness of your limbs.
No, nothing like that.
Okay. Any sense of dizziness.
No, nothing like that. No.
Okay. So you said that you have also vomiting.
Yes.
Okay. Okay. Is that vomiting? It's just a food, or it contains any blood? Sorry for asking, but it contains any blood or any the blood?
No, there's no blood in it. It's just like color of the
Okay.
food that I eat.
Okay. So any change with your weight? Have you noticed any
No, nothing. No, nothing
belly
like that.
pain? Any diarrhea? Any discoloration of your
No.
bowel motions? I mean, any blood with your bowel motion?
No, nothing like that. No.
Okay, so further, any problems with your water work? I mean, any reduction in the amount or any blood with it, any burning sensation?
Well, yeah, now that you've mentioned that, like I noticed that I've been going to the toilet less frequently lately. So yeah.
It means that it is reduced. Okay.
Exactly. Yeah.
Okay. Is this first time this occurs?
You mean like this what's happening to me, the nausea and the vomiting and
Yeah.
all that?
Yeah.
Yeah, this is the first time that happens.
Okay. So any flu-like illness preceding to that condition? I mean, any sneezing, any cough, any throat pain?
No, nothing like that. No.
Okay. Any change in the color of your skin?
No, not really. Nothing like that. No.
Okay. Any problems with your joints? Any pain with your joints?
Like recently I just like I had a backache, so I'm taking like drugs for it, so painkillers, so it's gone now. Yeah, it's controlled.
Okay. Okay. So you have a back pain recently, or it is just for a long period?
Yeah, like like in my work, so I just like lifted a heavy object. So yeah, I had like, I hurt my back, so I took painkillers for it. So yeah.
Okay. Any, let's say, diagnosed disease, any pathologies with your back, any previous diagnosed problem with your back? Do you have anything like this?
You mean problem with my back?
Yeah.
No, it's just like the pain that I had like 1 month ago, and I'm taking painkillers for it.
Okay. Okay. You continuously take that painkillers?
Yes,
I mean,
because
the
it helps
names
me
of
like
the
relieve the
kind of
pain. So yeah, I keep taking.
okay, their names. Do you have their names and how many drugs you take daily?
It's ibuprofen, and I take it like I think the dose on it is like 400 milligram. Like I take like a couple times a day. It's for the past month.
For the past month. Okay. Then
Yes.
before that, have no have not had complaints, but after starting these drugs, you have started that vomitings. Is that right?
Yes, exactly. Yeah.
Okay. Dear Mr. Brad, do you have any past disease? I mean, like a diabetes, like high blood pressures, any kidney problems, any liver problems in the past?
Yeah, I do have like high blood pressure, and I also have diabetes, and my joints hurt for a long time. So yeah, I keep taking medication for them. And I had like a heart attack once.
Heart attack once. Oh, sorry for that. The
2 minutes left. 2 minutes left.
Sorry. Mr. Murad, by now, do you have any concerns, any questions for me?
So I guess my main concern is basically like why I'm having this like vomiting constantly and this like nausea, because it's really bothering me, and I don't know like why is this happening? Is it like a stomach bug? Is it like something serious? So that's why I came here today. I was hoping you could help me like process this.
Okay, so by now I want to start my examination, generally examine Mr. Murad, including his vital signs, pulse rate, blood pressure, and his hydration status. Also, I want to examine his, of course, the abdomen at first, looking for any tenderness in the renal angle.
Okay, so shall we go one by one? You would like to have a general
Yeah.
examination looking at general state. The patient looks tired. He's dehydrated.
Okay.
Okay. There is very mild pedal edema, very mild, and his JVP is not he's not raised. Any other things you'd like to know? The general examination.
We said dehydrated, isn't it?
Yes.
Okay. I want to examine, as I mentioned, also the skin, especially the buttock and the lower legs, for if there's any rash.
No skin rash. There is no skin rash.
Okay. Okay. I want to examine also the back, because the patient complains of the back pain. If there's any local tenderness in the back.
Very mild.
And if there's any limitation, if there's any limitation of the movement in the back too. Okay.
Very mild tenderness and no limitation of movement. Yeah.
Okay. And also examine the abdomen, which
time finished.
Okay. I want to also examine the abdomen at this.
Sorry, Gaylan, time finished. Shall we go
Sorry. But Dr. Zainab, just it's in true exam condition. I'm continuing my examination and also answering the patient's concern.
Yes, time finished. Now the examiner's question time. Okay, so what's your most likely diagnosis?
My most likely diagnosis is acute renal injury, namely acute tubular necrosis, due to drug-induced harm. I would say drug-induced due to the nephrons. This is my first ibuprofen, the analgesia NSAID.
Okay, so what's your differential diagnosis?
My differential diagnosis is if there is acute glomerulonephritis due to let's say he acute glomerulonephritis, one of the differentials due to the other disease states. But on the path medical history, patients mentioned that he had diabetes, hypertension, and one heart attack, and other drugs. They also add the harm to his condition.
Okay, and how would you investigate this patient?
Firstly, I need an initial blood test, including CBC, and complete blood count. I need the renal function test, the liver function test.
You have the renal function in front of you.
Yes, it shows that. Yeah, it shows that there is a renal impairment, serum creatinine. I want to examine the urine, the urine examination, which is very important for me here at this stage, to see if there is any cast in the urine, if there is any protein in the urine, if there is any blood in the urine. So
how would you treat this patient?
This patient, because there is a renal impairment, I need to admit this patient to the hospital. Stop the offending agents, including the NSAIDs, IV hydration, monitoring the renal function. This is my initial
Okay. So if this patient was a 40-year-old female with the same exact scenario, what would you do?
The same exact scenario with the vomiting and renal impairment, 40-year-old female. I mean, you mean the differential diagnosis or the management stage?
Management. What would you do? Management includes, I want you to give me one investigation and one management.
I will do, let's say, autoimmune screen in a young female for any 40 years old. I will search for SLE-induced injuries in the kidney.
Okay, time finished. Go to the next scenario.
Okay. So again, good evening, Mrs. Good evening, Mrs. Hana Rasil. I'm Dr. Gaylan Shardar. I'm one of the junior doctors in the emergency department of the hospital. I'm seeing you to have a few. Sorry, Mrs. Hana, are you there?
Yes.
And you are 40 years old, I think. I guess
50.
50, sorry, 50 years old. I'm Dr. Gaylan Shardar. I'm one of the junior doctors in the department. I'm there to have a few chats with you for your current medical state. We will proceed for the examination. Is that okay with you, sorry?
Yes.
Okay. So can you elaborate more? In the paper that I have read, it says that you have some blurred vision, unfortunately. Can you elaborate more?
Yeah, well, it's been like for the past 2 months, my eyes hurt. So I went to my doctor, my eyes doctor, and he told me to visit you.
You have an eye doctor?
Yes.
Okay. So you have pain with your eye in the past 2 months. Am I right?
Yes, was aching.
Okay. Wait, is this first time you have this sense, Mrs. Hannah? Or previously have any diagnosed disease?
No, completely normal. But then I started to have this pain.
Okay, it's completely normal. This is first time. Is it continuous or it is intermittent? Coming and going? Attacks?
Well, it's not like attacks, but I feel like it's worse when I get up in the morning, you know?
It's early in the morning. Okay.
Yes.
Any pain, any redness of the eyes, any watering from the eyes?
Well, yes, I said it was painful, especially behind my eye and when I move it. And you said watering. What do you mean watering?
Any watering from the eyes? I mean,
oh no, but it is red, as you said. I feel like it's red, and when I look at the mirror, the white of my eyes is becoming a bit red.
Okay, Mrs. Hannah, do you have any headache, any dizziness, any disturbance with your consciousness last week?
No.
Okay, so your both eyes are having the same problem, isn't it? Or it
Y-
is one of them?
Yes, both of them.
Okay, is there any trauma to your eyes, to your head, or
No,
something?
no, no. I was super normal, but then this happens. This blurring of my vision.
Okay, do you have any pain anywhere in your body beside the eyes? I mean, the shoulders, the back, the joints.
No, it's just my eyes.
Okay. Recently, have you have any chest pain, any palpitation, any shortness of breath?
No.
Okay. So now I'm coming to that. Do you have any medical disease? I mean, high blood pressures, diabetes, any kidney and liver problem?
No, it's just migraine, the headaches, and
Mm,
eczema.
migraine and eczema. Okay. Do you take any drugs for them?
Yes, for migraine, I take propranolol, and yes, some ointments for eczema.
Ointments. Do you know the name of the ointments?
No, doctor says it just contains something called steroids.
Okay. Do you have any problem with the light, with the movements of your eye?
Yes, I cannot move them because when I look up, down, or even the sides, it hurts.
Okay. Anything makes it worse, the vision problem.
Make it worse. Oh yes, the light makes it worse. So
The light.
I have to like wear sunglasses, and I don't like sunglasses when I go out, but I have to wear them because the light is affecting me. I cannot
Okay.
tolerate it.
I presume that this condition affected your life, isn't it? Your work.
Yes, yes.
Okay. So by now, Mrs. Hannah, do you have any concerns, any questions that I can answer?
Well, I just don't know what is wrong with me. I was completely normal, and then this happened. So what is that?
Okay.
Will I lose my
Mrs.
vision because
Okay.
I'm not seeing well?
Okay. Mrs. Hannah, although I need to examine you, I need to examine your blood pressures in both your arms and your examination of your hand and examination. Okay. Now these are the findings. And okay. And I also have examination of your both eyes, including by using a tool which is called fundoscope, the back of your eyes, and need to examine your heads and muscles around your head. But by now, I can say you that I think that you have a condition which is called glaucoma. Mostly it's
2 minutes left.
okay, glaucoma, which is basically it is a rise in the pressure of the water. Before coming to that, your eye is divided inside into two chambers, and posterior chamber, back chamber, before the retina, and anterior chamber, in front of the lens and between the cornea. I think that there is increased amount of the fluid inside your eyes anterior chamber, which is exacerbated more by the drug that you are taking for your migraine. We call this condition as glaucoma, and we can manage this condition first of all by stopping your drug. I don't know how much it suits you, but we try to arrange that and you arrange your medication for your migraine. Stop that drug first and change it to an alternative drug, and then giving drops which are helping you to reduce the amount of the fluid. One drop is called acetazolamide, and the other one is relaxant, or sorry, the constrictant of the muscles, which also helps to reduce that pressure. Any other concerns? Any other questions?
Okay. I'm not sure that I'm following all the stuff that you said, doctor, but I'm expected to see the ophthalmologist today. So, will I lose my sight because I like reading and and this is affecting my eye. So is this treatable?
Okay, sorry for I think yeah, this is an overwhelming amount of information. We will today later on we consult the ophthalmologist. Just I like to explain it to you what we think of. We will
So time
consult the
finished,
ophthalmologist, senior
Gaylan?
ophthalmologist.
Time finished?
And okay,
What's-
thank
what's
you,
your-
Mrs. Anna.
What's your most likely diagnosis?
My most likely diagnosis is the glaucoma, open angle glaucoma, due to propranolol.
What are the positive features the patient mentioned in history that gave you this clue?
Okay, one thing is the pain of the eyes
Mhm.
associated with the redness, associated with the limitation of the movement of both eyes, associated with the blurring of the vision.
Okay. Any other features she mentioned?
Light induced pain.
Okay. What's your differential diagnosis?
My differential diagnosis, one differential diagnosis is for example, multiple sclerosis, primary progressive multiple sclerosis. MS.
Okay. How would you investigate this patient?
How we again I will send the basic blood tests, including complete blood count and inflammatory markers, CRP and ESR, and also do the visual field the examination, and include my clinical examination, do examination of the optic nerve, oculomotor nerve, and the fourth and sixth nerves, and I mean the trochlear and the additional nerve clinically, and doing the fundoscope in order to see the retina, and also doing the red reflex if I see there is a feature of cataract from the lens. Returning back to the clinically, referring the patient to the ophthalmologist will ensure the examination of through the slit lamp. Also, optometry.
Yes. Thank you, Gaylan. Gaylan, sorry. Let me reshare the cases. I stopped sharing them. So, for the first case, your diagnosis was drug-induced acute tuberous necrosis. Is that correct?
Yeah.
Okay. So it's partially correct. So you are right. Acute kidney injury secondary to ibuprofen, a non-steroidal anti-inflammatory drug, which he's been taking for the past 4 weeks. But you have missed 2 medical emergencies which were given to you in the case vignette. Do you remember them?
Yeah, the high blood pressure, emergency hypertension, I think. Am I right? Okay. So I think this is one. And hyperkalemia too. Both of them are emergency conditions to be treated.
Exactly. So although you've got the diagnosis right, this patient is having acute kidney injury. We don't know this acute kidney injury, is it because ibuprofen or is it because of the hypertensive emergency? Okay. We still don't know. So we need to investigate that. But it's very important not to miss medical emergencies because patient safety here is compromised. And that's, even though you have addressed patient concern, you've taken the history, you've asked what to do, perform examination, you weren't a safe doctor in this scenario because you missed 2 medical emergencies that you should have mentioned in your management plan for the patient and your management plan discussion with the examiner.
Very
Okay.
nice. Very nice. All right.
Yeah, I mean, history, of course, we need more practice to be more fluent in taking history, be more time efficient. You managed to ask about examination because it was a verbal. So I gave you the findings verbally, but in real life, you will need time to check general signs, dehydration, check the legs, examine the abdomen. So we need to be more time efficient when taking history. Try to extract the information from the patient which are relevant to your. So I intentionally, by the way, this one and the second one, the 2 cases were my station 5 cases. So you need to, I intentionally put the first scenarios, the first three scenarios with vomiting, but each one, although it has vomiting, it has a different diagnosis. And you only know the diagnosis by taking a proper history and performing relevant examination. So all of them had vomiting, but one was pregnant with DKA, the other one had gastroenteritis with hyponatremia and adrenal insufficiency, and this one had acute tubular necrosis with hypertensive emergency and hyperkalemia. Okay. The second scenario, but I don't know why you thought about glaucoma. Is in a glaucoma you can't move the eyes?
To be sure, the whole picture actually, I depend on the whole picture.
You asked
Exactly, I
about
don't know.
diplopia.
I think I have asked about blurred vision, but
Any
not
eye
exactly about it.
history, in addition to asking about a painful vision, red eye, visual acuity, you need to make sure that photosensitivity, you need to make sure you ask about diplopia, you need to ask about the progression of symptoms, you need, and usually in medicine, as far as I know, they don't bring glaucoma cases in medical exams, as far as I know, but Dr. Dikra can correct me if I'm wrong. The common eye cases in medical exams are the uveitis, thyroid eye disease, and you need to make, and cellulitis, orbital cellulitis. So you need to make sure you exclude the medical causes when you ask questions. So this patient had thyroid eye disease, and it was a presentation, and thyroid eye disease in 30% of the patient precedes the presentation of thyroid. So you can see a patient without any thyroid symptoms, or they are euthyroid, and they just present for the first time with this thyroid eye disease. So the questions you need to ask instead, in addition to visual acuity, blurring of vision, redness, painful, dry eye, grittiness, these are typical features of thyroid eye disease. Diplopia, particularly, it starts with vertical diplopia. Patient can't read, or they miss stairs, or they fall off stairs because they can't see them, because of the inflammation of the inferior rectus muscle, and then it progresses. So this is a mild thyroid disease, thyroid eye disease. Then the longer the duration, the worse the activity of the disease, the more features you see in terms of reduced visual acuity, color desaturation, which starts with the red color desaturation. So you need to ask about the colors, color vision, and then of course it ends with blindness, which is an ophthalmological emergency. So this patient was having severe thyroid eye disease, which is manifested by the reduced visual acuity, and she needs admission. She will need to have steroids and refer to ophthalmologist for radiotherapy and decompression of her orbits to relieve the optic nerve. So unfortunately, this wasn't a correct one. I mean, I would put the glaucoma as a differential diagnosis, but I would put medical cases, causes as my first line.
Very nice.
Because Dikra wants to comment.
So, Dr. Zainab, thank you for these lovely scenarios. Like every day we see cases like this. So truly very thankful to you. And I feel again for lovely candidates, the doctors, because they don't have the advantage of having the patients and examining them. In the first scenario, blood pressure, of course, is measured very high, potassium is high, urea is very high. So it is very emergency case. And the patient concerns are not met very clearly. This patient, again, emergency, regardless what is the cause. It is acute kidney injury, maybe acute only chronic because he has diabetes, he has hypertension. And as Dr. Mentioned that he is on ibuprofen, so maybe drug-induced is very good, differential, but it wasn't like very clearly put to the patient, and there was no clear management to the patient, assuring him that you need to be admitted, blood pressure need to be lowered down, and to deal with the very high potassium. It is another emergency emergency situation. With regard to the second case, yes, you were maybe more thorough in taking the history, but the diagnosis was completely wrong. Again, you were not able to examine the patient vision or looking at if there is any proptosis or ophthalmoplegia in support of thyroid disease, or even at least examine the neck if there is any nodularity in the thyroid glands. But again, you jump to bilateral glaucoma. It is emergency. It doesn't come in the exam. In the exam, it comes maybe optic atrophy or simple background retinopathy or laser treatment for diabetic retinopathy. These comes, but not a glaucoma, because it is emergency things. And then you ruined your, probably, if I was to empathize with you and give you a pass mark for a diagnosis, you mentioned multiple sclerosis. It's highly unlikely to happen that way and to present that way at this age for the first time. So MS is unlikely. I would have probably accepted you want to consider raised intracranial pressure, maybe, but it is not there. You need to rule it out. I might have accepted giant cell arteritis because, again, painful eyes, blurred vision, I might have accepted it. But I think, again, you did not pass the skills meant to pass, so I apologize. Another thing, this is what we need to probably make sure. You have been using jargon words, sentences, because these patients are lay people, they layman language. They don't know what is maybe not a glaucoma, or you said raised intraocular pressure, something you have mentioned twice, which is not accepted in these exams. So you have to use the right and the correct explanation for what you mean, so they accept it from you. So again, we need to practice a lot. So the whole skills you have mentioned is not very satisfactory to me. If we are to empathize with you, because you've done a lot of information you gathered, maybe in some skills borderline. I want you to make to know very clearly that this exam is not, it is the examiners has to struggle to be very fair to the candidates, and our aim is to probably pass as many as we can if you are slightly drifting from the right way, but we can be very brutal and sharp if you speak like jargon or give clinical information inappropriate or wrong diagnosis, or more important is to jeopardize the patient's safety. You need to be very careful not to lose any marks on skill G. It is very important not to cause harm, neither verbally nor physically. So I think you need to practice a lot on these skills. And good luck.
Thank you, Dr.
Thanks a lot, sir, dear seniors, for your work. Thanks a lot for your videos.
Two more
Thanks a lot.
tips
Good
to
night.
mention. When you go the wrong way in the exam, when you don't examine, or when you take the wrong history, or when you mention the wrong information to the patient, no one will correct you. So the examiner will leave you. Just go with your own flow, and they will just sit there and watch you. So don't expect anyone to tell you that you haven't examined. You need to examine, or you're going we are east and you're going west. No, don't expect that. And the other thing, sometimes patients intentionally hide information, but maybe someone told them to hide it. I don't know why. I mean, in my exam, this was my case, the thyroid eye disease. I specifically asked the patient, do you have any history of thyroid problem? He said no. I asked him about all thyroid symptoms. He said no. And then when I examined him, I found a thyroidectomy scar on his leg. So I don't know, this might not happen in Iraq in the mock exam, but it happened to me. So you need to have a very, I don't know, very low threshold of suspecting the common things. Don't think about the uncommon things, think about the relevant medical things, and all the scenarios in PACES are medical. Or like, for example, medical ophthalmology, medical, they wouldn't bring ophthalmology on its own, like glaucoma, they would bring medical ophthalmology, like uveitis, optic neuritis, or whatever.
شيء أنا كان
Any
ماشي
question?
يبقى ماشي
Yeah, any
Thanks a lot,
questions?
Dr. Zainab.
You're most welcome. Oh, just one more thing I remembered. I forgot to correct Mahmoud on the first scenario in the management of hypernatremia. We don't give half normal saline. We give hypertonic saline, 3% or 2.7%, whatever is available. But we don't give hypotonic because this will kill the patient. Any questions, Omnia, before we move to the next, to our last?
Yes, we have a couple of questions in the chat. So, wait. For case 1, acute renal failure, acute and chronic, and severe hyperkalemia, for me needs urgent dialysis. Am I right?
Not always. Dialysis is not the first line treatment because it's difficult to, I mean, I'll leave this to the nephrologist to talk about it, but it's not the first line treatment. You need to manage them medically first. And if they didn't improve on medical treatment, then yes, dialysis would be the option. And he's not reaching the parameters for dialysis yet. Creatinine 350, and we haven't even tried any medical treatment to lower his blood pressure or correct his urinase before going to dialysis.
So regarding case 3, why is it not adult polycystic kidney disease, especially given the severe hypertension and the previous renal impairment? Also, the station is station 5 and expecting finding examination like masses of polycystic kidneys.
Sorry, are they talking about the first scenario or this one?
For case 3.
Why not adult polycystic kidney disease? Okay, so nothing in the history, so we need to exclude that in your history. Nothing in the history to suggest this is adult polycystic kidney disease. And the patient age as well. If there were any cysts, they would have shown by now, would have been shown by now. And on top of that, family history doesn't also suggest that it's an autosomal dominant. So definitely there would be a positive family history. So this is excluded by your history, asking for to check urine for hematuria, ultrasound, kidneys, and whatever family history needed to cover this. History of brain aneurysms, subarachnoid hemorrhage would also suggest that. Yeah. This is a very clear, there are very clear causes in this history. Patient with hypertension, non-steroidal anti-inflammatory drugs. These are two main problems the patient is facing, which are very likely in this scenario to explain the diagnosis. You can put adult polycystic as a differential, but not as a first line.
Thank you so much. So I guess now we move to the final round.
Good. Who's our next candidate?
It's me, Dr. Amir.
Amir Ali.
Amir,
Yes.
okay, so you also have 5 minutes. Let me get my timer ready. And it's our last scenario. And of course, again, you will start with Ibrahim and then Omnia. We'll be simulating. Okay, 5 minutes, go ahead. Okay, Amir, would you start, please?
Yes. Good evening.
Good evening, doctor.
Yeah, my name is Dr. Amir. I am one of the doctor in the clinic today. Can I confirm that I'm speaking to Mr. Salwan Majid, 55 years old?
Yes, that's me.
Nice to meet you, Mr. Majid. So, Mr. Majid, we are here today to discuss about your health condition. Would that be okay with you?
Yeah, sounds good.
Okay, so I've been noticed that you have been dealing with raising of the heart. Is that correct? Hello?
Yeah, my heart's been like beating fast.
Mm-hmm. Okay, and for how long you have been this problem?
It's been happening for like 2 months now.
For 2 months. Okay, and is it started like suddenly
Yes.
or gradually?
No, it started like it was gradual because now it's beating so fast that I can barely breathe and I feel like so tired. So yeah, that's why I came today.
I'm sorry to hear that. So you have this racing of the heart whenever you exert yourself, or do you have it even at rest or sometimes at sleep?
Yeah, it's like all the time when I walk, and it's even like at rest when I'm sitting down. So I feel like my heart is beating fast and in a fuzzy way.
Mhm. Okay. Okay. Is it regular, like I'm tapping on the table in front of you, or is it like this regular?
No, it beats like too fast and irregular.
Fast and regular. Okay. And what do you think makes it worse?
I'm not sure. Like I said,
Mhm.
it happens like when I'm
Mhm.
sitting down, when I'm walking, when I'm moving. So
Mhm.
I actually
Okay.
can't tell.
So it comes like in episodes, or is it like continuously?
No, it comes and goes. Like it comes like for sometimes
Mhm.
like few couple seconds or minutes, and then goes away and back and forth.
Okay, I got. So do you have any other complaints like chest problem, chest pain maybe?
No.
No chest pain. You said you have a little bit of shortness of breath. Is that right?
Yes, exactly.
Okay. Is there any like shakiness of the hands or the abnormal
Uh,
movement
no,
maybe? No
no,
shakiness in your hand at all? Okay. Any
no,
sweating at all?
no.
No sweating. Okay. So any history of any past medical history of note?
Um, what do you mean? Like, so
Do you have
I
any
have
chronic
like
disease?
high
Any
blood.
long-standing illness?
I have a high blood pressure, and I also have diabetes. One time I had like a heart attack, and doctor
Heart
told me
attack?
like I have
Mm-hmm.
something called hay fever.
And hay fever. Okay. And are you taking your medication for all of these conditions?
Yeah, I do.
Okay, good. Maybe we can come to this later. Okay. So
Sure.
do you have any history of high temperature?
No.
Okay. Any history of cold intolerance or heat intolerance?
What do you mean by that?
Do you find it difficult to adjust to the cold weather or maybe the hot weather?
Not really. No, it's normal for me.
Okay. Any history of weight change, maybe weight gain or weight loss?
No.
Okay. Regarding your medical history, are you on any medication at the moment? You said you have high blood pressure and high blood sugar.
Yes. So yeah, like I said, I take my medication for like what I have regularly. So yeah.
So can I see your medication list? What do you take?
Sure. So I take amlodipine, 10 milligram, and also take metformin, 1 gram. Also atorvastatin, aspirin,
Mhm. Okay.
and also some antihistamines.
Okay. Antihistamines as well. Okay. And is there any over-the-counter medication maybe not included in these
No.
lists? Okay. Can I ask you, Mr. Majid, are you taking any illicit medication?
Like what?
maybe some recreational drugs?
Oh, no, nothing like that.
Okay. Do you have past medical history of note?
Past medical history of what?
Any past medical history in your family?
Oh, yeah, my dad had also had a high blood pressure,
Mhm.
and he actually died of a heart attack when he was roughly 60.
I'm sorry to hear that, Mr. Majid. So,
Thank you.
any herbal medication maybe?
No.
No. Can I ask you, Mr. Majid, do you smoke?
Yeah, I do.
And for how long and how many cigarettes per day?
Actually, I smoke like around 20 cigarettes a day, something like that. Yeah.
And for how long?
To be honest, I can't tell. It's been a long time.
So, Mr. Majid, smoking is really dangerous for your health, especially for your past medical
2
history.
minutes
I
left.
would suggest to stop smoking. I can refer you to smoking cessation clinic. Mr. Majid, may I examine you?
Sure.
I need at this point to examine the pulse of the patient bilaterally, and also I will examine his blood pressure. Then I would examine the heart of the patient, looking for S1 and S2, and if there are any abnormal murmur.
Okay, so pulse
And
is irregular and fast, but symmetrical bilaterally.
irregular, I'm sorry.
Irregular and fast. Okay, and
Okay.
symmetrical
The patient said
bilaterally.
irregular.
Mhm.
Okay. Yes. Mhm.
What else?
And symmetrical bilaterally. Okay. All right.
Blood pressure is, you have it in the observation. It's 150 over 90.
Great. Okay. Any murmur, any added sound?
No added sounds.
Okay. I will need to examine also for carotid bruit bilaterally.
No carotid bruit.
I also would offer fundoscopic examination.
Normal fundus.
All right. So, okay, I get back to the patient. Mr. Majid, what is your concern?
Actually, I'm just like worried about what's happening with me lately because, like I said, I've been feeling like very breathless all the time, and I'm actually afraid that I might actually die early, like my father, because of what's happening to me. Is this like another heart attack or what? So I was hoping
So,
like you could help me with that.
yeah. Yeah. So, Mr. Majid, from our discussion and our brief examination, it seems to me that you have an irregular heartbeat. And this is mostly because of your past history of high blood pressure and high blood sugar, as well as heart attack. So it is not another heart attack, as you mentioned, but
Okay.
it can be dangerous. That's why it is very important now to do a heart tracing and do some investigation. And we'll have another sit down and to talk about the results of investigation.
Time finished. Amir, okay, shall we go to the question? So what are the causes of palpitations? Just name 3 or 4 causes.
So in this patient is with the past medical history, I
In
believe
general, what are the causes of palpitations in general?
palpitation in general, like if it is regular or irregular. If it is regular, mostly if like it is sinus tachycardia or maybe due to SVT, and if it is regular, mostly it is due to atrial fibrillation.
Any other causes?
Any other causes of regular ectopic beats also could be an irregular ventricular ectopics also. Yes.
What is the most likely diagnosis in this patient?
So the most likely diagnosis here, I would need a heart tracing or an ECG to make sure the patient having either if it is ventricular ectopics or atrial fibrillation to be exactly sure.
Okay, so if it was AF, what type of AF it would be?
So it would be a paroxysmal type of AF because the patient,
okay.
Yes.
And what are the complications of AF?
So the complication we are mostly worried and most feared complication is having a stroke because of embolic phenomena. Embolic stroke from heart source. Stroke is one of the complications.
How would you investigate this gentleman? In addition
So
to heart tracing, what would you do? What blood test do you send?
blood test. Blood test, blood urea and serum creatinine, renal function test, and I would also send for serum troponin, maybe, although the patient didn't have any chest pain or signs of heart
Okay.
attack.
Time finished. Shall we go to the next scenario?
And INR, if I may say. Yeah, okay.
Next scenario. Yes.
Yes.
So,
Yes.
good evening.
Good evening.
My name is Dr. Amir. I am one of the doctors in the clinic today. Can I confirm that I'm speaking to Mrs. Rajia Yahya, 70 years old?
Yes.
Nice to meet you, Mrs. Yahya. So we are here today to discuss some of the recent symptoms of yours. Would that be okay with you?
Yes.
So, Mrs. Yahya, I've been briefed that you have been having recurrent, back pain and recurrent falls. Can you tell me more about this?
Yes, doctor. Like one day ago, I fell. I like didn't haven't been able to move, and my leg slipped, and then I fell. I was on the floor for like hours because I couldn't get up. My
I'm
legs
sorry to hear
felt
that.
weak.
I'm sorry to hear
Yeah.
that, Mrs. Yahya. So you said it is like one day ago you had this fall,
Yes.
and have you had any falls before this fall?
Yeah, I have. Like, it's not like falls, but the pain, the pain was there before that fall.
Okay, so regarding this last fall, you said yesterday,
Mm.
and would you tell me more about this? What did you feel before you fell down?
Well, nothing, just my legs felt weak, and then I fell. And then when I
Okay.
wanted to get up, I couldn't. So I lay on the floor until my husband and children came, and then they took me to the hospital.
I'm sorry to hear that. Are you now in any pain? Do you want some painkiller?
Well, yeah, because the pain is severe and it is not going any slower. So
Okay, I would offer the patient at this point a painkiller. All right. So, Mrs. Yahya, you said you have been on the ground for several hours. Did you maybe hit your head? Have you hit your head when you fell down?
no, nothing
And
like
have you
that.
lost your conscious?
No,
Have you didn't lose your consciousness? Okay. And before you fell down, did you like tripped in any, or maybe hit the floor, tripped in the floor, or you felt your legs are weak and you fell down?
yeah, just the weak legs.
Okay, and you didn't had any like maybe some racing or pacing of the heart before?
No, no such thing.
No. Okay, and maybe any dizziness when you stand up?
No, nothing like that.
Okay, so you were trying to stand up from a sitting position, or you were standing like for a long time when you go to the floor?
No, I told you I was like working in the house, and then I felt my legs weak, and then I fell. And this is the first time that such thing happened. Told you it was just a pain.
Okay, I'm sorry to hear that. So, had you had any like abnormal movements?
No.
All right. Any bleeding from anywhere?
No.
Okay. And what happened after that when your husband found you?
Well, they took me to the hospital, and I'm here now
All right.
to assess
Okay.
myself. So
Yes. So do you have any past medical history of note, Mrs. Yahya?
yeah, like 1 month ago was this pain in my back. It kept on, and then it kept worsening. Yeah, that was the thing that bothered me and affected my life.
I'm sorry to hear that. We try to solve this issue for you, Mrs. Yahya. So and not any other past medical history of not like high blood pressure, high blood sugar?
Yes, I have high blood pressure and I have asthma and thin bones. Yeah, I think my
You have
doctors told me that.
all right, and you have this back pain. You said for how long?
Yes, for 1 month till now.
For 1 month now. No, okay. And is there any test or any workup had done for this back pain?
No, just took some painkillers at first.
You took some painkillers, all right. And what did you take? What did you take?
Well, I don't know. It's just like this paracetamol and ibuprofen, those sorts of painkillers.
Okay, and regarding this ibuprofen, how much do you remember you took?
Oh dear, I don't remember.
Like on regularly you are taking, or only some few pills maybe?
Well, when the pain strikes, I go forward to the drug. So,
okay. And is there any problem with your water work? Any decrease in the amount or any decrease in the amount?
in the amount of what?
Of your water work?
What's that?
Of your urine?
Oh, no, I haven't passed, as you asked now, I haven't passed any urine since the fall.
You haven't
I
passed
want to
any?
go to the bathroom, but
All
yeah,
right.
I haven't.
Okay. And have did you experience any other problems, like any shortness of breath?
No,
Okay.
no, but just my appetite isn't as before, so.
Okay. Any feeling sick or vomiting or throwing up?
No.
Okay. At this point, I need to examine the patient. First, I will go for the pulse and the blood pressure. Can I
You have
examine your
2
eyes?
minutes left.
Okay, I will examine for any color of the conjunctiva. And also for the JVB. Another thing I will do the first, if there any tenderness in the back.
Yes, there is this in the back.
Okay, I will ask the patient, I will leave this. So I will also examine lower legs for pedal edema.
No pedal edema.
All right. Mrs. Yahya, what is your concern? Hello, Mrs. Yahya? Yeah. What is your
sorry,
concern,
what was
Mrs.
the
Yahya?
question?
What is your concern at the moment?
My concern. So first of all, this is the first time that such thing happened, me going to the floor and not being able to get up. So what is that?
Okay. So, Mrs. Yahya, from our discussion and from our brief examination, it seems to me that you have weak muscles around your hip. That's why you fell down to the floor. And regarding your back pain as well, we will need to do some blood tests, and we'll also need to do some of imaging to make sure we are reaching to the bottom of this problem. Is that okay with you?
Thank you.
Yes, thank you.
Thank you, Mia. Okay. So what's the most likely diagnosis for this patient?
Okay, for this patient from her lab, and I believe that the patient had rhabdomyolysis from her fall. The patient has been having back pain and she fell down to the floor. She stayed like for a few hours with her renal indices and hyperkalemia. I believe this is a case, especially the patient has not been having any urine output, as she mentioned. This is a case of proximal myopathy maybe, or any other form complicated by acute kidney injury and rhabdomyolysis.
What's your differential diagnosis?
All my differential diagnosis, although I would like to put an acute kidney injury due to non-steroidal intake, especially the ibuprofen the patient mentioned. I don't know if it is an acute or chronic. I would need to do an ultrasound and also some other investigation, blood investigation as well.
How would you manage this patient?
So regarding admission, I will admit the patient. I will start with the hydration, and I will also put a urine catheter. Another thing, I will give normal saline, and I will do a multidisciplinary team to inform the nephrologist to put him on board with this case. And I will do a complete blood count and ESR straight to protein. I'm concerning also about multiple myeloma here, so I will do ESR and urine and plasma protein electrophoresis and serum calcium, magnesium, liver function test as well. Okay.
I'm finished. Thank
Imaging
you.
as well.
Thank
Yes.
you, Omnia.
Thank you so much, but please just be mindful of the time.
Yes, yeah. So
Thank
be
you.
very quick. How much time do we have?
Time's up already, so
Oh, sorry about that. Okay, so the first case was a patient with palpitation. Your history was good. You tried to explore the differential diagnoses related to palpitations. I felt you were asking about thyroid, but you didn't mention that in your differential diagnosis and in your management plan and investigations. So you need to make sure that you are thorough when you ask history, and you are thorough when you are mentioning your differential diagnoses as well as the investigations you'd like to request. The other thing, other differential diagnoses you need to keep in mind and ask about is anemia, pheochromocytoma, and anxiety as well. But this patient had a fast AF, and which was relevant to his past medical history.
So I'm sorry, the surrogate told me he's having a regular type of palpitation. And during the examination, it was irregular.
So yeah, it's ideally should be irregular. I'm not sure. I didn't hear Ibrahim well, but sometimes patients say things wrong because they don't know. So you need to as
Okay.
well to rely on your examination. But I honestly, I didn't hear that well. I think he said irregular, but I'm
And
not
I
sure.
also put hyperthyroidism, pheo, alcohol, caffeine, cocaine. I will also
Yes.
put them in my differential, stress and anxiety. But I
Yes,
thought you are
exactly.
asking me about regular and irregular. I'm sorry.
Yes, initially I asked about causes of palpitation, so you need to mention them all. And this patient, he has AF, he has a significant cardiovascular history, and he has significant factors in his social history, which are the alcohol intake you didn't ask about, as far as
Yes.
I hear,
Yes, yes.
and smoking history. He's a heavy alcohol, has heavy alcohol intake. He has heavy caffeinated drinks intake. He drinks 3 to 4 cups of coffee a day, plus unhealthy lifestyle, high BMI, and poorly controlled diabetes. So he's very high risk from the cardiovascular point of view, which needs to be addressed when you address the management of this patient. The second case, patient kept mentioning that she felt weak, she couldn't get up, and she couldn't pass urine. So these, I agree, fall, long lie, rhabdomyolysis, which would explain her kidney functions. But these are red flags for spinal cord compression, metastatic spinal cord compression. You did mention multiple myeloma in the investigations, but I was waiting for you to mention metastatic spinal cord compression and multiple myeloma as your first thing that you need to rule out before ruling out other causes. This was a case of anyone who has unexplained new back pain, unexplained change in his or her mobility,
Yes.
and unexplained change in the bowel motion or urinary, like bladder activity. These are red flags that you need to keep in mind. Okay, so this is another medical emergency, which is that needs to be managed instantly. Okay, immediately without any delay. All right.
So it is osteoporotic fracture or multiple myeloma?
This is a differential diagnosis. Osteoporotic fracture is a differential
For
diagnosis.
differential,
But the
yes.
first thing that you need to show the examiner, the patient, and everyone, patient with sudden loss of power, unable to get up, which is unusual to her, complaining of urine retention since yesterday, immediately. You need to keep metastatic spinal cord compression in your mind. You need to request an MRI urgently that should be done within 24 hours to rule out spinal cord compression due to metastasis. These are the
Yes.
first thing you do. Then the rest will come along. But the metastases are the first thing. Myeloma screen and everything related to malignancy screen needs to be done first or alongside others. Okay.
Yes.
Yeah, so the safety issue here is not addressed well with the second case, but the first case was borderline, I would say. I would leave Dr. Dikra to comment if she has anything to say.
اليوم they may not like me today at all. Normally, my feedback from the college, I am a bit more dovish than hawkish, but today I've been very hawk. I want everyone probably to learn from the mistakes we do in the proper exams. So in summary, I think we are getting better. Slowly, the history taking is getting better compared to the first and the second scenario. Yes, as you mentioned, your feedback to Amir and Ibrahim is very good, Dr. Zainab. Yes, you mentioned that cord compression is very emergency and one has to be very careful not to miss it. And it is usually we miss it every now and then. In the first scenario where the palpitation, yes, thyroid function test is needed. I think we were a little bit slow in arranging the investigation. So time in this station is very important to practice and to keep your questions very quickly and arrange tests, because if you don't assess one of the skill, you will get 0 for it and you will lose marks. So in general, I think the management in the second case is better than what it was before. So you referred him for MDT, you have done a lot of tests, you have hydrated him. Anyway, your management was better. Still borderline, and in some skills you did not pass this skill. So sorry to say, this session today was not the best, and the exam was not very satisfactory today.
Thank you. I would like to thank Mahmoud, Kailan, and Amir because
Yeah.
they are very, very brave.
Yeah, they are
easy.
very brave. And I sometimes, I mean, today, to be very honest with you, I hesitated to appear in this session. I didn't want you all to feel I am a senior examiner watching you doing these things. I hope I did not cause any unhappy feeling that my presence affected any one of you. But I am here only to support you and to give the best feedback. And my aim is to wait and see all of you pass the PACES exam. So if you don't want me in the future in these sessions, please do not hesitate. I will not take it personal. I can probably leave it to the very capable Dr. Zainab and Dr. Wathiq and everyone. So good luck to all.
I mean, personally, I think your presence is important. It's very important to have the other side point of view to see, to assess performance, not only because after all, I'm not an examiner, so I think your point of view is very, very relevant and very important.
Yeah, and believe me, we all learn from each other. Every time we go to the exam as examiners, and no matter, I've been examiner for 12 years, every time I go to any exam, I have to go through back again all the criteria and the scoring. It has to be a fair assessment, and it has to be very realistic. I must say something. I know the time has ticked up. Please make sure that we give on the 27th of April, there will be a meeting on up-to-date on we call it PACES 23. all these scenarios will change. All these stations will stay 5 stations, but it will change. So I am more than happy to participate with Zainab, Wathiq, or anyone who is happy to share another meeting to update everyone on the exam, because I have a feeling that when the exam is hosted in Iraq, inshallah, in the early 2024, it will be the new set. So we have to be prepared for that from now. And inshallah, when we come in March and give the mock exam, we will talk about this PACES 23 in more details. So I think I will leave you to it tonight. You had enough of me, and good
I would
night.
also thank Omni and Ibrahim for helping me through the session. And thanks again to Mahmoud, Gailan, and Amir, because without you guys, the session wouldn't have gone through. And apologies for the harsh feedback we gave you, but definitely after this, you will be much, much better. So thank you. Thank you so much. I'm happy to help, and I'm happy to do another session if you like.
Thank you so much, Dr. Zainab, and all the candidates for their participation. So sorry, because we moved over the time.
Just
Yes.
one last thing to say, if they like the way we did Station 5 today, I'm happy to do it again. If they feel that there's a better way to do it, that's more interactive rather than waiting for, including only 3 people to interact during the session, then that's fine. Whatever they feel, if you could do a survey, whatever they feel it's more appropriate to do for
Yes.
PACES workshops, please let me know.
Yes, so everyone, we have a feedback form that we posted in the chat. So please go over the feedback and type all your opinions and thoughts. It is very important for us to update and develop our workshops. Thank you so much, Dr. Zainab and Dr. Dhikra, for your comments and feedback. And inshallah, we will see you in the upcoming workshop. Good night.